Hi, everyone. Thank you for the opportunity given to present here today on behalf of the VIRCAN Group, our abstract. We are all very much aware of the fact that viral hepatitis accounts for a significant economic and health burden in Canada, and also that in 2016, Canada signed on to WHO's global viral hepatitis strategy with a goal of eliminating viral hepatitis by 2030. It is also estimated that more than 45% of individuals with chronic hepatitis C infection in Canada remain undiagnosed. For that, scaling up ACV screening and linkage to care programs is essential to achieve WHO's targets. To address this need, the Toronto Centre for Liver Disease at UHN implemented an integrated care model, the Viral Hepatitis Care Network, or VIRCAN, which integrates a comprehensive outreach program in the community with education, research, screening, diagnosis, and linkage to care needed to eliminate barriers to care in the Greater Toronto Area and Ontario. So, understanding current rates of ACV diagnosis and linkage to care in different community settings is critical information for developing future screening strategies. Our aim was to evaluate ACV screening strategies implemented in 3 different community settings as part of our VIRCAN program: emergency department, medical walk-in clinic, and community outreach. In the emergency, we implemented birth cohort ACV testing in the emergency department and walk-in clinic, and universal ACV testing during the community outreach. We developed customized screening and linkage to care protocols for each setting, and trained non-healthcare provider testers on pre- and post-test counseling, ACV antibody point-of-care testing, ACV antibody and RNA testing using the dry blood spot collection cards, and on linkage to care protocols. Once verbal consent was obtained, the interested individuals were registered and tested, and we follow up on the results and provided linkage to care. The blood samples were collected by finger prick in emergency department using the dry blood spot collection cards and tested for anti-ACV with reflex to ACV RNA. In the medical walk-in clinic and community outreach, we used the ACV antibody point-of-care test, followed by the ACV RNA test using the dry blood spot collection card on those individuals who had the reactive antibody point-of-care test. All the steps were also collected by finger prick, and patients with positive ACV RNA are linked to care in all groups. Approximately 6,000 patients were tested between April 2017 and February 2019, with the majority, nearly half of these individuals being tested in the community outreach group. The median age was 56, and if we are looking at the age-sex distribution by location, we noticed that the medical walk-in clinic group the individuals tested were younger, 51 versus 58% in emergency, 51 versus 58 in emergency department, and also more females were tested in the medical walk-in clinic versus the other 2 groups, approximately 60% versus 48% in the emergency department. This graph shows the percentage with positive test with a 95% confidential interval overall and by location. The serosensitivity varied among all 3 groups: 1.8% in the emergency department, 0.4% in the walk-in clinic, and 5.6% in the community outreach. The ACV prevalence in the community outreach and in the emergency department was significantly higher than the general Canadian population. However, the ACV prevalence in this emergency department birth cohort was significantly lower than the one seen in the emergency departments in the United States, 1.8% versus 10.3%. If we look at the ACV cascade of care, overall, 85% of individuals with a reactive ACV antibody test underwent ACV RNA testing, with emergency department having the highest confirmatory testing uptake. Approximately 70% of the individuals who are tested were confirmed to be ACV RNA positives, and 92% were linked to care. In conclusions, the ACV prevalence in the community outreach and emergency department was significantly higher than the general Canadian population. Using the dry blood spot for ACV testing ensured a high ACV RNA test uptake, and screening efforts in populations with higher prevalence, such as the emergency department and outreach programs, resulted in higher yield and good linkage to care. This is a snapshot of VIRCAN's presence in the community. And I would like to conclude by acknowledging that this work couldn't have been done without the assistance of the staff and volunteers from VIRCAN, Toronto Centre for Liver Disease, Walking Clinic, Albany Walking Clinic, and Toronto Western Emergency Department, as well as all the other community partners. And very important, our collaboration with Mount Sinai Hospital Lab and Public Health Ontario Lab. Thank you.
Hi, that was really nice. Thank you. I was wondering if you can comment on some of the reasons why people hadn't progressed to the RNA testing. Because when you described in your methodology, I just assumed that everyone was going to get an RNA test because you called it reflexive. But it seems like lower. Why is that? Do people get their finger prick test and then just run away?
Yes. So in the community outreach events, some patients don't have the patience to wait for 20 minutes for the ACV antibody test result. We have a team that we try to make all the efforts to link these patients to care and follow up with them after the event. However, some of the challenges were for a special patient population where they don't have a fixed address or contact information. That still remains a challenge.
So do you think it's better just to collect the dry blood spots up front and just skip the point of care antibody test?
Yes, it is possible, yes.
Thank you very much.